Thank you, Kathy. Welcome, everybody. Welcome to the January 2022 quarterly APCD Data Users Group. This is our 10th one. It seems like yesterday, but 10th one. It sounds a bit cliche, but so. For those of you who are new to these sessions, and I hope there are some new folks, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, or the HTI, and is administered by the Arkansas Center for Health Improvement, ACHI, which is us. The Arkansas APCD is comprised of private carrier and public payer medical, pharmacy, and dental claims, and all sorts of other interesting data as well, such as birth certificates, death certificates, hospital inpatient data, etc. Additionally, well, and as I was saying, it enables these data, the use of these data sets from the Department of Health. And I do want to especially mention the cancer registry data and the medical marijuana cardholder data. We hope that you find today's session helpful. We invite you to ask questions using the chat function or reach out to our team after the session if you have anything, whether it's a question or you just want to do some discovery on the project that you have. Let's go to the next slide. Well, this is the next slide. Sorry, my script was behind. So the topics for today are listed here, and we have a guest speaker. The first subject will be the impact of insurer size increase on negotiated prices, evidence from the ACA in Arkansas. And that is from one of our data requesters, more in a moment. The second is Arkansas Medicare data use methodologies, presented by one of our own SMEs. As usual, we will talk about release information and data tips, and then have questions, discussion as needed. Next slide. So I'm Kenley Money, the Director of Information Systems Architecture, or the APCD Director here at ACHI. Our guest speaker, Chivon, we'll talk about him in just a moment. And Edward Choi from ACHI is our Senior Data Analyst. We'll talk about Medicare. Edward, I think I pronounced your name incorrectly. My apologies. First things first, then. I'm sorry, go ahead. Go ahead, Edward.
Oh, that's fine.
Okay. He can correct me. I was reading fast. We are going to use Mentimeter again to collect survey information. There are slides placed at the beginning and the end of this presentation to capture feedback. Let's go to the next slide. And what we'll ask you to do is go on your phone or a different browsing window and go to menti.com. And when we start the Mentimeter survey at the next slide, you'll see a code at the top. This is an example. This is not the code for this session. You'll enter that code, and when prompted, with the reference box, you'll see a screen with a question and answer options, and you can enter your feedback. And this saves us all from having to do a survey at the end of the presentation. Next slide. So there's our code, 90937806, and we'll give you a second to go to your phone or to another browser window, and you can enter the name of your institution. And your role, if you're faculty, if you're a student, private, so. Good. That's great. I see lots of different roles. I see some data requesters from the private sector, from state agencies, from UAMS. Excellent. I see a guest. Great. Very nice. All right. Let's go to the next slide, Kathy. The next question in our survey is this the first time you've participated in the data users group discussion? I have a lot of repeat people. Oh, it's getting. Okay. Well, welcome to the new person. Welcome. Let's go to the next one. What is your analytic skill level? Don't be afraid. APCDs can be complicated things, and we are here to help all. And if you're a beginner, that's great. Hopefully you'll learn something today. Let's go to the next slide. What types of health insurance administrative data have you worked with before? Click all that apply. Yep. Great. Okay. And how likely are you to use the Arkansas APCD? Who should you call? We'll have contact info at the end. Okay. Okay. All right, Kathy. I think that's our last question, right? So this section is with our guest speaker of sorts. Chivon Choi from Lehigh University was one of the APCD's first data requesters. At the time, he was with Cornell. He acquired APCD data in the fall of 2018 for his projects, and these slides represent his latest published work. Unfortunately, as we were scheduling this, it turns out he has conflicts, Chivon has conflicts, but he recorded his presentation for us. He has provided his email in this presentation and invites anyone to reach out to him with questions and comments. We'll make his slides available to everyone on the APCD website when we make these slides, the overall slides available. It will be recorded. This session is being recorded, so you have a choice, this recording or a separate slide deck. And that way you can get his contact information and look at his presentation in more detail. I'm going to go off video and I'm going to let Kathy begin the presentation.
Okay, give me just 1 second to do this. That did not work, so I'm going to play.
Stand by.
First time, I'll be there in a second. Yeah. Shit. Do you see a black screen?
Yes, we do.
All right.
Hello, everyone. My name is Chivon Choi, and I'm from Lehigh University. In this presentation, I'm going to talk about my research project in which I'm using the Arkansas APCD data. And I would like to thank the Arkansas APCD team for giving me this opportunity to talk about my work in the webinar. And I'm sorry for not being able to attend the webinar in person because of the schedule conflict. And I hope you find this presentation useful. So first, let me introduce myself a little bit more. So again, my name is Chivon Choi, and I'm currently an assistant professor in the Department of Economics at Lehigh University. I'm originally from Seoul, South Korea, but I received a PhD training in economics from Cornell University before joining Lehigh in 2020. And I'm an applied microeconomist, and my research fields are health economics and industrial organization. And the topics I'm interested in include how the public and private sectors in the US healthcare interact with one another, and the effects of healthcare reforms in the US, such as the Affordable Care Act. And this is the structure of this presentation. So first, I'm going to talk about the main research question of this paper, and I will talk about why I chose the Arkansas APCD data for this research, and I will show you the key results from the paper, and I'm going to discuss some of the difficulties I have experienced with this data set. So the main research question of this paper is whether larger private insurers in the US healthcare have bargaining advantage when they negotiate with medical providers for healthcare prices. And this is not a new topic in the literature. And there have been many empirical studies documenting the buyer side effect in the US healthcare setting. This means past studies have found that larger insurers tend to pay lower prices for various kinds of healthcare services, including hospital services, pharmaceutical drugs, and professional services. However, the primary limitation of these previous empirical studies on this topic is that they're mostly based on cross-sectional variation in size across insurers. The main concern with this approach is that insurer size may correlate with other important factors in price negotiations, such as an insurer's ability to steer patients across different providers. For example, if larger insurers tend to have better abilities to steer patients across providers, then the estimation of size effect from this cross-sectional setting may not be reliable. In other words, it will be hard to tell whether the effect is from the variation in size or from the variation in other factors correlating with insurer size. So the main goal of my paper is to empirically measure the insurer size effect in healthcare without being affected by this concern. So then why did I choose Arkansas APCD data for this research? First, I was interested in Arkansas because of its policy change that is closely related to the insurer size effect. Arkansas is one of the 38 states, including the District of Columbia, that expanded their Medicaid programs through the Affordable Care Act of 2010. And what makes Arkansas special among these 38 expansion states is its unique way of Medicaid expansion. While most expansion states use exclusive plans for Medicaid beneficiaries called Medicaid Managed Care plans, Arkansas used individual plans for its Medicaid expansion. And individual plans are a type of private health insurance plans in the US designed primarily for non-Medicaid beneficiaries. As a result of the Medicaid expansion in Arkansas, about 250,000 individuals newly gained insurance coverage, and because of the state's unique approach, they were injected into its individual market. This resulted in a significant enrollment increase for the largest incumbent insurer in the market. And what is crucial about this enrollment increase in Arkansas is that it is in large part exogenous, which means it's less likely that this enrollment increase correlates with other important factors in the price negotiation, because the enrollment increase was caused externally by a policy change in the state. So this means Arkansas individual market provides a rare empirical setting where a researcher can study the effect of exogenous size increase of an insurer on its negotiated healthcare prices. So this is why I selected Arkansas APCD data for this research. As you know, Arkansas APCD data contain enrollment and healthcare claims data for commercial health insurance plans in Arkansas from 2013 to 2020. So from the enrollment data set, you can identify which individuals are covered by individual plans as opposed to group plans like employer-sponsored plans. And you can also use the data set to tell who are covered by Medicaid or not. And more importantly, claims data set contains key variables for this study, such as allowed amounts, which are often used as the negotiated prices in healthcare research, and procedure and diagnosis codes, including DRG codes, patient demographics, including age and sex, and provider identification. So because the Medicaid expansion took place in 2014 and Arkansas APCD data starts from 2013, by comparing the negotiated prices between before ACA and after ACA individual plans, technically one can measure the effect of the ACA-induced enrollment increase on negotiated prices. So that's what I did in the paper, and here are some of the key results from the paper. First, I found that the negotiated hospital prices for the largest insurers' individual plans decreased by 18% on average from 2013 to 2015. And this is after controlling for patient demographics and case severity. And in the paper, I also provide several supporting evidence for the argument that the documented price reduction for the largest insurer in Arkansas is mainly contributable to the size increase due to the ACA Medicaid expansion. First, I found that a competing insurer in the market whose enrollment increase after the ACA was not so significant as the largest insurer did not experience the price reduction. And second, the price reduction for the largest insurer is found to be higher in the counties with larger shares of non-elderly populations who are eligible for the ACA Medicaid program. Third, the price reduction is found to be higher for the kinds of services consumed in higher volume by the newly insured Medicaid beneficiaries. And finally, I also found that the prices for the largest insurer's individual plan did not decrease from the hospitals in neighboring states, in which its enrollment did not increase. And for this analysis, I used the claims in the data set for Arkansas residents who used hospitals located in the neighboring states. And also in the paper, I show that the key mechanism behind the price reduction is by the improvement in bargaining position of the insurer as a result of the size increase. And I also estimate the savings in healthcare expenditure as a result of the price reduction. So if you like to learn more about these additional findings in the paper, please refer to my paper, which is available on my personal page. And I will wrap up this presentation by sharing with you some of the difficulties I have experienced with this data set. First point is, and this is not just for Arkansas APCD data, but APCD data only cover healthcare claims from a single state. So this means APCD data in general may not be ideal for comparative studies in which compare one state with other states. In addition, one of the most common feedback I received for this research is whether my results can be generalized into other states. So this external validity issue is something you have to think about carefully when you use APCD data in general. And the second point is there's a limited amount of information about individual characteristics in the data set except demographics. So for example, in my case, there was one variable in the data set which can be used to tell who are covered by Medicaid or not, but there was no information about household income, which is an important criterion for Medicaid eligibility. So if you're doing economic research like me, then you may want to have access to individual level socioeconomic variables, but in the data set, most of them are not available. And the best you could do, I guess, is merging external aggregate level data into your APCD data. And the third point is not all variables are complete. So this means some variables like member race from the enrollment data set do not have values for most observations. And presumably this is because it's not mandatory for insurers to provide data on these optional variables, but at first it may not be so clear which variables are optional and which variables are not optional. But the data dictionary indicates which variables are optional and which variables are not optional. So this is something you have to check before using this data set. And the final point is related to the Affordable Care Act, like my paper. The ACA took into effect in 2014, and the Arkansas APC data starts from 2013. So this means there's only 1 year of data in the data set before the ACA. And of course, having 1 year of data is better than having nothing. But in some panel studies, this may be problematic because having multiple pre-treatment data is often desired in panel studies. So this is something you need to check before using the data as well. So that's all I have for this presentation. So thank you for listening. And if you have any questions or comments, you can reach out to me by email. And I hope you enjoy the rest of the webinar. Thank you.
Okay.
Great. Thanks, Kathy, for making that happen. And everyone saw that Ji-Hung offered his email address at the end, and we can make that available too. And also, if you saw I put it in the chat for everyone, but we discovered late that he had placed the wrong date at the beginning of on his first slide. It's 2022, not 2020. Anyway, so we plan to have more presentations about our data use in the next user groups. So if you are close to the end or have already published from the work that you have done, I ask everyone in the audience, I will probably reach out to you to determine if you're interested in presenting it to this group. It's always valuable to know how folks are using the data and get some insight into challenges and how to overcome them. All right, let us move to our next topic. And I am going to turn this over to Edward, and he can correct the way I pronounced his name. My apologies, Edward.
That's fine. Yeah. Hey, everyone. My name is Edward Tavia, and I'm a data analyst with ACHI, Arkansas Center for Health Improvement. Today, I'll be talking briefly about some Arkansas Medicare data use methodologies, zoning in on considerations of the use of the master beneficiary summary file. Now, for data requesters who utilize our Arkansas Medicare data, you may have heard of the master beneficiary summary file. This file is like the member file that is available upon request, just like other APCD files, but in a completely different format from the APCD. But think of it as a member file equivalent for Medicare claims. Now, the aim of this presentation is to point out some nuances in the data to be mindful of when using the Medicare member table. I'll talk about challenges with variables related to gender, age, and race in the Arkansas Medicare data. Next slide. So we'll first examine gender. Usually the gender variable is coded 1 for male, 2 for female, and 0 for unknown. And there are like less than 11 per 60 million data points. So The unknowns should be the least of our worries. But I'd like us to take a look at the distribution of gender of two common cancers known to occur in males and females, comparing that to national data. So looking at the table, we're starting with prostate cancer in the US. As of 2018, 0.02% of females in the US and 0.09% of females in Arkansas have been diagnosed with prostate cancer, which is known to affect males. In the same period, looking at endometrial cancer prevalence, 0.03% and 0.16% of males in the US and Arkansas respectively have been diagnosed with endometrial cancer, which is known to affect females. So you may be you may consider excluding these individuals from your study if it's consistent with your research goals. Now, how we identify these individuals with these conditions was using flags in our member beneficiary summary file, the one that has chronic condition flags. And these flags are available, in the data set just to identify individuals with these conditions. And the flags were created from the chronic condition warehouse in CMS. They had an algorithm that is used to identify individuals with these conditions. Next slide. So let's talk about age. There's been persistent concerns that some deaths are missed by Medicare program or Social Security Administration. Of course, Medicare obtains its deaths information from the Social Security Administration. And so these individuals may appear to be alive and actively enrolled in Medicare when in fact they're already deceased. So look at the table below. This is the table lists the number of individuals in the US by age group of people 90 and above as reported by Medicare in 2010 and census in 2010. And we're using 2010 census and Medicare 2010 because the other years off of census, of course, you know that they are estimates. So the 2010 census is a more solid way of comparing what the actual numbers might be. And the table, this table is coming out of ResDoc. So for the first row, individuals that's aged 90 to 94, the disparity you can see is pretty huge between number of individuals enrolled in Medicare and the census count of that age group. The difference is about 500,000, which is, saying that there are about 500,000 more enrolled in Medicare than even reported in the 2010 census. This suggests that assuming everyone in that age group enrolled according to the census number, 30% more people are enrolled in Medicare than were not counted in the 2010 census. The next row for age 95 to 99 had about 80,000 more in Medicare. That's also like 18% more. But the biggest was the individuals in the 100 plus group that had 85% more, representing 56% more in Medicare enrollment. We also compared enrollment in Arkansas Medicare in 2010. So just a reminder, this table is all of Arkansas, all of Medicare data nationwide. Okay. However, we did compare enrollment in Arkansas Medicare in 2010 to number of individuals in the census and found that those 65 and above, we found 12,000 more enrollment in Medicare than in 2010 census. Now moving on to, yeah. So moving on to the next, actually, let's stay on this slide. This is the slide that I wanted to talk about. So does that mean that the data is all bad? No, it just combining the data with other sources, gives us helpful clues as to what to do next. On this slide, you can see that what immediately pops up is the bars for individuals age 100 plus. Now the height of the green bar represents percent of individuals in that age group who have no healthcare use. Okay. And in other words, these individuals have neither Medicare Part A, Medicare Part B, or Medicare Part C. While the blue represent percent of individuals in that age group with no Part B claim. Okay. And just to bring a little bit of context, Part B covers doctor and other healthcare provider services and outpatient care. Part B also covers durable medical equipment, home healthcare, and some preventive services. So you would think that individuals, 100 plus of age would at least use one of these services. And it's not surprising that looking at the green bar, it goes to about 50%, meaning that the 50% of individuals enrolled in Medicare in that age group that have no healthcare use. Okay. Next slide. So knowing this, I would like to share some tips on age considerations, or when using the age in your data set. Okay. There is no standard or consistent way to remove these people. One option is that anyone over 100 or 90 who has no healthcare use in 1 year could be removed from the study population. Also, anyone over 90 who has no Part B coverage could be removed as well. And of course, anyone older than the oldest person in the US, you could consider removing them. But even if there's individuals 100 and over represent 0.44% of all of Medicare population. So understanding your eligible population may be helpful as well, because in some eligible populations, this 0.44% might be significant depending on your study. Next slide. So I'd like to wrap up and talk about race a little bit. Race in our Medicare data. When Medicare began collecting race information, there were only white, black, and unknown designations. But from 1994, it was expanded to include Asian, Hispanic, and Native American races. And if actually the current data users would already know that these are the designations in the race variable, in the beneficiary race code. But even this designation is not in line with Office of Management and Budget, which requires separation of Hispanic ethnicity from race. In fact, in the APCD, we do not have Hispanic value for race, but it could be specified under ethnicity. But this is not the beneficiary race code, isn't the only race code in there. But before I go there, let me just state that the Hispanic race or ethnicity code has an estimated sensitivity of about 35%. Think of it as how good this variable is able to identify a Hispanic individual correctly. There is another race variable in our data set, popularly called the RTI race code. For those who use the data, you may have seen it. It's a derived variable, and the algorithm was developed by the Research Triangle Institute, and hence the RTI acronym. Now, this variable is created by taking the beneficiary race code, which is the original one in Medicare, that has historically been used by the Social Security Administration, and then applying an algorithm that identifies more beneficiaries as Hispanic or Asian. Okay, so the ITR race imputation algorithm utilizes lists of Hispanic and Asian or Pacific Islander names from the US Census, and then simple geography like residents in Puerto Rico or Hawaii to improve on the race assignment. There is one article, suggesting that the RTI race code has about 90% sensitivity and high specificity of 98.8. We have not come around to use it, one, because it's a direct variable, and two, we haven't gotten the chance to review the specifics of the algorithm for Arkansas' use case. So that's all I'd like to share with you on this piece of information on the Medicare member beneficiary summary file. Thank you so much.
You are welcome. You are welcome, Edward. So there was a comment in the chat. Worse, OMB mandated use of Hispanic as an ethnicity in 1997. It's been a long time with a smiley face. We all are challenged with that. And for the group, a quick peek into a future change. And for those of you who do know what I'm about to explain, apologies for the repetition, but here we go. We get our data based on a layout that's identified in a document called the Data Submission Guide. We deliver the Data Submission Guide, or DSG, to the carriers, and they have to build the files accordingly. And periodically, we make changes to the Data Submission Guide. There's a very detailed process. It takes about a year to do. But for the Data Submission Guide changes that are included for this year, we are asking for a Hispanic indicator and some additional race information. I think a topic for our next data users group, or maybe the April one or the June one, would be what changes we're going to put in the Data Submission Guide for your awareness. That doesn't mean we'll get data retroactively, but that does mean that going forward, we can count on some more data to help us through these race and ethnicity challenges that Edward so eloquently described. So, okay, that said, let's go to our next topic, which is the data release information and data tips. Next slide, please, Kathy. This is a bit of a repeat from the last data users group, but because we haven't had a database change, the current database has data available from January 1st, 2013 through December 31st, 2020. We have just begun the last bullet. I'm going to skip to the last one. Our next build, and it will be out late spring, and it will include data through June 30th, 2021. So, excuse me, with each build, we publish release notes, and if Kathy, do you have those up? We can just zip over there. It's not a video, thankfully. If not, then, well, okay, she'll get there. But if you're using any of the databases, I highly recommend that you go to the release notes just so that you can see what has changed in that build. Sometimes if you have data from an older build, a change has occurred. The problem will have been illustrated or documented in the release notes associated with that build, but it may have been fixed we try to keep you as informed as possible. Kathy, if that's problematic, I'm more interested in the data tips here on the next slide. She's working through it. There we go. Okay, thank you. When you go to the release notes, you can click there. It's on the APCD website. There will be references to lots of other documents. And as always, I recommend that you look at the documents, especially the one called data attributes, because it will help you understand how to link the data, link members, enrollees across data. Okay, let's go to the next slide. Because we will, don't forget, always check your data tips next. Okay. As we normally do on this page, we offer some interesting new data tips, and I will speak to them first, and then we're going to go to something new on the data tip page. So 1 second, and I will go. We've added a few new data tips, but the 4 I wanted to introduce you to are these. The first one is a tip, not an issue. It addresses what a difference in the data early on. So EBD is the Employee Benefits Division, and it contains all the claims for the public school employees and the Arkansas State employees. And early on, and until the next bill, there wasn't clear subscriber information with the data that we got. So we replicated the member data in the subscriber fields. And for those of you who are familiar with how our data structure is, there are member fields like member year of birth and member zip code and member state. And then there are also associated subscriber fields. But we have 2 EBD experts on staff, and we were able to, with their input and a lot of data mining and data discovery, figure out how to identify the subscriber. It was not clear from the EBD system directly. So we have updated the subscriber fields for EBD members, and this data tip will give you information on how to do it. The next one, we got a question in the chat. I'm embarrassed to say a bit ago. And it was about the flags for ICD-9 and ICD-10 diagnosis and procedure codes in the Medicare data. And in the Medicare data, which, as Edward explained, we get Medicare data from ResDAC, which is the Research Data Center. And they work for CMS, and they manage all of the Medicare data for researchers. And we purchase the data from them. Well, in the claims tables, and there are all sorts of different types of those, but ICD fields have ICD codes have an associated field that indicates which version, ICD-9 or ICD-10. And if at first glance, it looks like there are no ICD-10 codes, because whereas the flag for 9 would have a 9 in it and 10 is supposed to have a 0, there was no 0. And so the person asking this question said, why are there no ICD-10s? ICD-10 has been around since 2015. Well, it turns out that Medicare or ResDAC did not flag ICD-10, they just left it known. So the Medicare data does have ICD-9 and ICD-10 diagnosis and procedure codes. If you use the identifier field, know that ICD-10s have no value, it's null, and the 9s have none. So that is a tip now. The next one is an issue: incorrect open enrollment segments. So we have found that in 3 of our carriers, there, if you go to this tip, you'll list it, but I'll just read it here. You'll know, our carriers are identified by the entity ID 12231 River Valley, 90328 First Health, which is an Aetna. River Valley is a United carrier, and then 12567 Care Improvement. I think that's a United carrier too. all of these had transitions to other systems and other carriers to finish some of these plans, and they did not submit the appropriate enrollment segment closure. Let me explain. So for River Valley, the carrier 12231 River Valley no longer submits data to us. All of those members are on a different carrier now, a different united entity. And we expected them to send closure segments so that it looks like all those members had their coverage stopped on River Valley, but and then started again on the new one. And you can track this through member ID and or hash ID, but they didn't send closures. We are working with them to send closures. So it looks like on River Valley, for example, there are several active members when you do that. So this is in the issue data tips and issues, and it's also in referenced in the release notes. So there are workarounds in the data issue. So when you go to this link, you'll see them. The last one is very similar. It's disenrollment dates that are 9999-12 it's 12/31/9999 or no in the disenrollment date. Those two values indicate that the segment is open, that this member is still currently active, but there are still some outside the three carriers that I just described. There are some other nuances with there. So read both of those tips together. That said, oh, and if you have any questions, do not hesitate to reach out for more detail. Our team will get on the phone with you and work it out. So Kathy, can we go to the tip sheets? And I want to show everyone the change and the enhancement we've made there.
Yes, we can. Hold please. Go here and share. This is the regular tip and issue page.
Yep.
Some of you may have seen. I believe what we're going to talk about is over
That's
here
it.
on the right, the featured data tips and issues.
So we find that, and you'll agree, I'm certain that there are a lot of data tips and issues, and you never know what is new or changed. So we have added this feature to our site that highlights the latest, the newest data tips or the most recently changed data tips in the last 30 days. So you can go here and not have to search for what recently changed. And our hope also is to start a regular correspondence, maybe in the months between data users groups, so that everyone will keep abreast of this. And it may be as simple as saying, please go check your data tips. Something's changed. That is being developed. But this shows you, it takes you right to the newest and the latest changes. Go back up to the top, Kathy, and you can get back to the main data tip page by clicking that right there. And that just takes you back.
You can also navigate over here on the left.
Thank you.
Sometimes the menu is hidden, but I did want to point out the featured ones are at the top, the regular ones are next, and the release notes are also over here. So here are your latest release notes. These can be downloaded, and going forward, we are going to have them actually created in Confluence. So there'll be a page, which I believe you can also download if you wanted to.
Yeah.
All right.
So Kathy, there was a comment in the chat. Would you take a look at that?
1 second. ACHI change. Okay. Yes, we have stopped the questions page, mostly because it did not alert us when you asked a question, which was not a good thing. So now, and I may add this on some more pages, but if you have a question, you can go to the overview page. And if you need more help or you want to ask a question, you go to our support portal. If you have a specific area, you can look up a article on it, or if you just want to ask your question,
Yep.
click data inquiry and you can add your short question and then add more description of your problem underneath, and that will send it to us and also alert our team that the question has been asked. And if it is applicable to all, we'll add it as a tip, but we will answer your question directly to you as quickly as possible. Okay.
So if you'll toggle back to the deck, that question was very timely, actually.
Yes. And go.
Go to the next slide.
Nope, wrong button.
There we go. That will, that's the slide that describes everything that Kathy just said. I'm going to point out that don't forget, if you're interested in a one-on-one meeting with our team, reach out and through the support portal here, and we're happy to do it. We're happy to address any question that you have, or just think out loud about how to use data. We are here to support you. All right, I think let's go to the next slide. And this is, we have just a couple of survey-like Mentimeter slides. Overall, how would you rate the presentation? You'll go to your browser. Okay. Nine. All right. Okay, let's move. What topic would you like to see in the future? If you have one handy, please put it here. Otherwise, you can shoot us an email through the support portal. It doesn't just have to be a question. We get a lot of our topics from your suggestions. Is there more to that? You can finish that request in the portal. Let's move to the next. Oh, wait, are covered in the APCD. Okay, that is those are all great questions. There is a slide on our website that can help answer the red and the yellow there. And out of state use, that's great. Great. Getting started with the APCD, great. We can cover all that. More research results. Yes. Yes. Compared to census. Interesting. Okay. Okay. All right, 10 seconds, then we'll move to the next one. All right, let's go to the next slide. How could we improve the discussion? Everyone's thinking. All right. If you think of something later, again, don't hesitate to drop us a line. The poll is too small, full question compared to the US. Okay, thank you, Don. Thank you. I'm sure that Kathy wrote that. Okay. Let's go to the next slide. Thank you, Don. And again, one-on-one meeting. Would you be interested? When you know your homework, let us know. Okay, good. Next slide. Call to action. This is how you get hold of us. Follow ACHI. And our next data users group is April 27th, 2022. And I believe that's it. If you'll, the next slide is a graphic that asks you to subscribe. Everybody, thank you so much for joining us today. It was a good session, and we will have the recording and the slides posted very shortly. And again, reach out to us if you have any questions. Thank you so much.